I think most of the audience know that the immune checkpoint inhibitors, after its introduction in 2013, it caused what's known as a shift in cancer management in general, and their use was associated with survival improvement and also overcome the outcomes for many tumors were improved after this introduction. So these are my objectives. I will discuss the prevalence in brief, the prevalence of triple-negative breast cancer in Saudi Arabia, and then I will discuss with you the key characteristics of triple-negative breast cancer and why this type of tumor or merit I will present, which was published in the field of oncology. So this is my disclosure. Okay, moving to the cancer incidence report, which was published last year, and the data was for 2016. Unfortunately, we don't have like annual reporting for the cancer cases. And anyhow, we have around the overall prevalence of breast cancer was around 18% diagnosed cancer in 2016, with around 2,240 cases in the same year. So with the median age of 15 years old. Unfortunately, our cancer incidence report doesn't include the type of the molecular subtypes of breast cancer. Before we discuss the molecular subtypes, I just want to tell you that fortunately, most of the cases when they are presenting to our hospitals, they are either localized or having regional diseases. Fortunately, only around 12 or 13% of the cases will present with advanced disease or metastatic disease. So I reviewed the publications for these molecular subtypes, which is really important in guiding us for choosing the best treatment option. So we know that breast cancer is not only one disease, it's many subtypes, many diseases in one disease. So according to the recent literature, Dr. Thibeti here in Western region presented a retrospective study. They included all breast cancer from 2012 until 2018. And what they found that triple-negative diseases was only 16%. So this is comparable to the what has been reported in the international figures. The other types, the other three subtypes were luminal A and luminal B, and here to enrich subtypes. Luminal A is defined as patients with estrogen receptors positive or progesterone positive and HER2 negative with low Ki-67. Ki-67 is very known as a prognostic factor or represent the mitosis of the malignant cells. Luminal B is another type, is again hormonal positive disease, but it is associated with, or it has the high Ki-67. Again, the triple-negative cancer is defined as subtypes of breast cancer where the patient has no positive biomarkers. What I mean by biomarkers is mainly estrogen and progesterone receptors as well as HER2. So that's why we called it HER2 negative disease. It accounts internationally from 15 to 20% of all breast cancer, which is comparable to our data here in Saudi. So most patients, unfortunately, they will present with very aggressive presentations. So they don't have options. In the past, we used to have only chemotherapy or systemic as a systemic management, plus the radiotherapy and surgery. So there was a need for a new class or new pharmacological option for those kind of patients. Unfortunately, those patients, they don't survive long. According to the literature, only around 12 to 15 months the survival rates for those group of patients. So after the approval or introduction of immunotherapy in many tumors, there was a huge effort to conduct many clinical trials to prove the effect of immune checkpoint inhibitors in this subgroup of patients. So immune checkpoint represent very promising treatment strategies for triple negative. That's why the pharmaceutical companies and researchers were interested to test these immune checkpoint inhibitors in this highly aggressive disease. And this slide is just to show you the landscape or the FDA timeline for the approval of immune checkpoint inhibitors. The first immune checkpoint inhibitor was approved back in 2011, which was ipilimumab for melanoma. After that, until this moment, we received like hundreds of FDA approvals for a wide range of indications. Most importantly is among these immune checkpoint inhibitors, only atezolizumab granted the FDA approval in 2019 for triple-negative breast cancer. So this slide represents the huge investment by pharmaceutical companies in conducting clinical trials in all phases. So as you see, the number of clinical trials is really huge. And these two balls here represent the immunotherapy targets. In 2017, for example, the researchers were looking for 263 targets, while in 2019 the number is doubled. So they are investing on these class of medications, and we are expecting more and more approvals in near future. So moving to the clinical characteristics of triple negative. So why triple negative disease may respond to immune checkpoint inhibitors? The first reason is that these type of tumors will have more TILS, which is tumor infiltrating lymphocytes. With high level in these subtypes, this may correlate with a response rate or improve in the response rate, especially in early triple-negative breast cancer. The second reason is that TNBC is associated with high expression of PD-L1. So PD-L1 expression is high in this subgroup of patients. So this represents a target for immune checkpoint inhibitors. And the last important reason is that these tumors may cause a huge number of mutations. These mutations may stimulate the tumor-specific antigens that will lead to stimulation of T lymphocytes and enhance or augment the immune system to fight against these cancers. Okay, moving to the after the approvals of after the introduction of immune checkpoint inhibitors to the market, the researchers were trying to use these agents in metastatic setting. So, but unfortunately, they used it as a single monotherapy agents. As you see in this table summarizes the minimum or marginal benefit of these medications in metastatic setting. As you can see here, the PFS range from 2 to maximum 3 months if they use it in single agents. And unfortunately, most of these trials were not practice-changing trials. After this, I can say failure of improvement of the survival or progression-free survival in TNBC, they moved to the next step, which is combining the chemotherapy with immune checkpoint inhibitors. In this part of my presentation, I will say in next part I'll present 3 practice-changing clinical trials. The first trial was in early triple-negative breast cancer, which is Keynote 522 trial or 522 trial, and the other 2 clinical trials in metastatic setting, which is IMpassion 130 and Keynote 350. We'll start with the first clinical trial, which was Keynote 522. In this clinical trial, it was phase 3 randomized clinical trial. They stratified or they randomized patients into 2 main groups. The first group received chemotherapy with immunotherapy. The backbone chemotherapy was carboplatin plus paclitaxel for the first 4 cycles. Then another 4 cycles of AC or EC chemotherapy plus the pembro 200 milligram every 3 weeks. The comparator arm was placebo plus the chemotherapy. Those patients received a new adjuvant phase, then the second phase was in adjuvant setting. The primary outcomes were the pathological response rate and the second and event-free survival also as a primary endpoints. In the secondary outcomes, they were looking for also PCR, but with overall survival as well. These are the baseline characteristics in 522 trial, in Keynote 522 clinical trial. As you can see, both groups were balanced. what's really important here is that they included, most of the included patients were PDL positive, around 83 or 80% of patients were PDL positive. Again, the tumor characteristics, including the size, most of the patients were T1 and T2, while around 30 or 25% were having huge tumor size. Another important point in this figure is that they included 50% with node positive and 50% with lymph node negative. This table summarizes the primary outcomes. As you can see, the difference here is around 15% between two arms. So the interpretation of this table is that pembrolizumab with chemotherapy improved the pathological complete response by almost 15%. The event-free survival at that time, when they presented this study in last San Antonio, it was not mature, but it was also statistically significant in terms of the reduction in the recurrence rate. Moving to the subgroup in this trial, they found that this benefit of enhanced and pathological response was seen among all the patients, regardless the PDL expression, and also regardless the chemotherapy backbone or exposure. I have to highlight one important point here from this table is that the majority of patients, or those patients with node positive disease, they benefited more. So the delta or the difference between two arms was around 20%. So as a conclusion from the keynote 522, the pembrolizumab plus chemotherapy improved pathological response rate in comparison to chemotherapy alone. And this benefit was seen in all group of patients, more specifically in node positive disease, and regardless of PDL expression. The second setting is metastatic triple negative breast cancer. We have two clinical trials. I will go over both of them. The first trial was IMpassion 130. IMpassion 130 actually was presented in last ASCO by Peter Schmidt in ASCO 2019. This IMpassion trial, actually, it was a double-blind clinical trial. 35 randomized patients, either atezolizumab every 2 weeks or nab-paclitaxel weekly for the first 3 doses, then the cycle will be given every 2 weeks versus chemotherapy alone. So 2 arms here, the primary outcomes were BFS and overall survival in both intention to treat, I mean the whole included patients, and they did subgroup analysis as well. As you can see from these 2 Kaplan-Meier tests, the progression-free survival was significantly improved in patients with PD-L1 positive TNBC. So with around 2.5 months gain in progression-free survival, and the hazard ratio was 0.62. So we have around 30, or can say 40% risk reduction in the progression of patients with PD-L1 positive TNBC. If you see this figure again in the left side, there is marginal benefit in progression-free survival in intention to treat patients. The updated results of IMpassion 130 showed that overall survival these two, so there was very marginal benefit in patients with PDL plus, PDL1 positive plus PDL negative. So the only advantage seen only in patients with PD-L1 positive disease, with overall survival advantage of this changing outcome. So based on the IMpassion 130, the FDA granted the FDA approval for atezolizumab in combination with nab-paclitaxel for management of PD-L1 positive metastatic breast cancer. And this is the safety profile. We cannot say that a new side effects. We know that inhibitors can co-mediate, and we know the side effect with using of nab-paclitaxel. So this is the conclusion of clinical trial. Again, that there was major benefit in terms of survival in PD-L1 subgroup with around 30% reduction in the hazard of death Okay, moving to the last clinical trial in triple-negative breast cancer in my presentation today, which is the Keynote 355 trial. This trial actually presented by Dr. Curtis in the last June, like 3 or 4 weeks ago. So in this clinical trial, Keynote 355 was a randomized, double-blind, multi-center clinical trial. Again, they included patients with triple-negative breast cancer, and they randomized those patients to either pembrolizumab plus chemotherapy versus placebo plus chemotherapy. And the primary outcomes were progression-free survival, overall survival, as well as the certification to subgroup both intention to treat and BDL positive disease. The secondary outcomes were objective response rate and duration of response rates, as well as the safety. Moving to the baseline characteristics of Keynote 355 trial, as you can see in this table, both arms were almost equal. They included patients in this clinical trials. They did what's known as CPS scoring system for the BDL expression. Again, majority of patients were BDL or BDL1 positive. And the background chemotherapy was either taxane or gemcarboplatin. Moving to the result, progression-free survival was significantly improved, 9.7 months versus 5.6, with hazard ratio of 35%. So this advantage only seen in patients with BDL1 expression or combined score more than 10. So as you can see, this result represents a practice-changing outcomes. We see here the progression-free survival also improved in patients with combined score more than 1. But unfortunately, this change or this level was did not meet the pre-specified boundary, so it was not statistically significant. So this BFS represents the intention to treat population. Again, the pembrolizumab with chemotherapy improved the progression-free survival, but it did not reach to the clinical significance or statistical significance. Regarding the safety profile, again, nothing is new. We know these side effects. Most of these side effects were comparable to what has been presented in the previous clinical trials. But I want to focus on one side effect, which was with pembrolizumab was higher than the other group, which is hypothyroidism. Hypothyroidism in the Keynote 355 trial was around 15%. So the physician should anticipate the side effects and manage those patients properly. So in conclusion to Keynote 355, pembrolizumab with chemotherapy improved progression-free survival in patients with metastatic triple-negative breast cancer with BDL expression more than 10. The BFS improvement reported across all patients, but the major benefit was seen only in patients with BDL1 combined score more than 10. The safety outcomes were almost comparable between two arms, and the investigator of this clinical trial said that this trial will add to what has been reported in IMpassion 130, and it will be to represent a new option for triple-negative breast cancer. So before I conclude my talk today, I would like to highlight a few points. First, the triple-negative breast cancer represent an unmet need. So those patients will have very aggressive tumors. That's why we need to have a new options, new treatment options. The clinical trials that showed the positive outcomes were discussed today. We have the new adjuvant pembrolizumab, and we have the atezolizumab and pembrolizumab in metastatic setting. So among these options, only IMpassion 130 medications granted FDA approval. So atezolizumab plus nab-paclitaxel is the only option that is presented today granted the FDA approval. So if you have a patient with metastatic triple-negative BDL1 positive disease, you should offer them the upfront atezolizumab with nab-paclitaxel. The other two options, pembrolizumab and pembrolizumab in neoadjuvant and pembrolizumab in metastatic setting, both options showed great outcomes, but until now we don't have the FDA approval yet. The pembrolizumab with chemotherapy backbone in the metastatic setting showed great outcomes, but unfortunately we don't have the overall survival data yet. And the neoadjuvant setting, the 15% or 20% improvement in the pathological response represent a great value, especially for patients with node-positive triple-negative cancer. So with these comments, I would like to conclude my presentation today, and thank you all.